Okay, I'd like to call it to order at 13:35. Dr. Lowry is no longer on the board, so until the replacement, I will be assuming the chair of the Quality Committee.
Congrats.
And Chuck, I want to thank you as chair of the board. I want to thank you for stepping back and doing this, so thank you very much.
Oh, this is fun.
Good.
Any citizens wishing to address the committee? Seeing none.
We have none citizens.
CEO update.
I do, really for quality, the only thing that I would give y'all is the meeting that we had yesterday, the joint meeting that we had was, I think, beneficial for all of us. And what we'll do is give you a little bit of a rundown at that when we have our full board meeting next week. We're not going to discuss any of the sort of the strategic approaches or anything else like that, because we haven't had time to really digest things. We were seeing the report, first time y'all saw the report in its totality. So we certainly appreciated the time and appreciated the efforts that we went through. But other than that, Mr. Chair, everything else we're going to bring up at full board.
Okay, anybody else? You folks got any questions for Robert? Matters requiring committee action, approval of the minutes circulated and they were on the portal.
Move approval of the minutes.
Second.
You got that, Ashley? Any discussion? All in favor, please say aye. Those opposed, same sign. Approval of Tarrant County Hospital District policies and/or plans. The first one is approval of 1C1, infection prevention and control, which is Wanda. Good afternoon.
This is just approval of our nurse staffing plan. This is a requirement by state board. We have a policy related to this, and it spells out what we do in the event.
Are you doing the nurse staffing now? First one up was the
Oh,
infection.
I'm sorry.
That's okay. You want to keep going with the nursing?
Thank you. I'm sorry. Getting ahead of
It
myself
was a
here.
fun event last night.
This first policy is our infection prevention control program authority and approval statement. This is stating that infection control has the ability to institute surveillance in areas that they deem necessary, and then to collaborate with outside agencies such as CDC in those areas, depending on if we need outside information from those entities, if we don't have that expertise here in-house.
We will need to approve these policies. Would somebody like to make a motion that we approve it?
Move approval of the infection prevention and control program.
Second by anybody? Second by DT. Any further discussion? All in favor, please say aye.
Aye.
Those opposed, same sign.
Okay.
The next one is
Okay.
your nurse staffing.
This is our nurse staffing plan, and this is a state board requirement, like I said, that we spell out exactly how we staff and about our nurse staffing committee, and that nurses have the right to file peer review, or if they have concerns with staffing, how they report that up, and then how we report that back, and that we do bring that information to you semi-annually to the board, and that there's certain nursing indicators that we monitor every year through ND and QI, and I bring that report to you then twice a year.
Talked ahead of time about one little change. Can we make that?
Yes, on section 6, it refers to, under D, it refers to the RN Nurse Staffing Committee. And in the title of that section, it just refers to the Nurse Staffing Committee. So we're just going to strike RN from that, because it's the same thing. There's not two different committees.
Yeah, we just take it out D. All right.
Good point.
Okay.
All right.
Okay.
Somebody like to
Move approval of the nurse staffing plan with the correction in section D.
All right, is there a second? Santa Rosa?
Okay.
Any discussion? All in favor, please say aye. Those opposed, same sign. Credentialing of allied health professionals. Thank you.
Thank you.
Very much. Chet.
Thank you, Mr. Chair. So MS 900 is credentialing of allied health professionals. The reason behind this is we have practitioners, well, practitioners is the wrong word. We have professionals who are in the hospital who provide care under limited settings and very specific scope of services that traditionally have been monitored by HR, but really over the last 5 to 10 years, there's a desire by Joint Commission to make sure that they are, that quality of care is being monitored by the medical staff. This here will allow us to have a blanket policy to apply to those professionals. We're going to start with perfusionists. So the idea is that it'll no longer be an HR function to bring in perfusionists, but rather the medical staff will assess the initial competencies. And then we'll be able to bring various other professionals to the board as we continue moving forward with that.
Okay, good. Do we have, let me ask, the perfusionist thing we have to approve differently? Do you want to hit that now, or does that go under the?
So it's initially listed on Appendix A in the policy, and so it would be, I think it would be an action that would be taken
Part of this would be approved. Okay.
now, but then it allows us to bring other individuals back and just under Appendix A.
Okay. Everybody got it?
Approval of the MS 900 policy by itself.
Yeah, and Appendix A, that's part of it. Definition of perfusionist.
You're right.
Yes, sir.
I have a question.
Well, wait, let me get a second first.
Second.
Okay, go ahead, Rex.
It says here that the list of allied health professionals under Appendix A, but there are only 2 listed. Is that all we have?
So,
No, but you, please.
yeah, I can explain. So there are a multitude that I think the medical staff would need to consider
Yes.
in terms of assessing quality. To implement it all at once would be burdensome on our medical staff office. Perfusionists are one of the ones initially that have the highest risk in terms of patient care, so we're starting there. But I would expect the board be presented with several different classifications of professionals over the next 6 to 12 months.
Okay.
You okay with that? Good with that?
I'm happy.
Okay.
Okay.
Small bite of the apple.
All right, okay.
I just had to ask.
Okay. No further discussion? Okay. For approval, vote yay.
Yes.
Yes.
Okay.
Vote for it.
Negative, same sign. Advanced directives, Laura Burnside.
This is going very fast.
I did? Or it- I'll come back. Let me- Laura, you're on your, you need to,
You need to come on, those guys, we're gonna have to separate them. We're gonna have to separate those
It
two.
it is my
Gotcha.
mistake.
No
So
worries.
please join us while we do.
If you would like to defer to Ms. Laura,
Uh,
I love and appreciate her.
Oh, man, just, go.
MS 1200 is a disaster privileging policy. This just allows a policy and procedure in the event we had a significant disaster to where we would need to allow medical staff immediate privileges. The procedure itself allows for that to be controlled by Mr. Early in conjunction with me, and puts very specific parameters on what folks can do for very, very brief periods of time.
Making a motion to approve that?
Move approval.
Nick, seconded. Any discussion about the policy? Those in favor, please say aye.
Aye.
Those opposed, same sign. You got the, Ashley? Thank you. Thank you, thank you.
My pleasure. Thank you for having me. I am here today to talk about two policies. The first one being RI 2000, which covers advanced directives. This policy was updated recently with very non-substantive changes to the policy. And what it basically covers is just the informing of every patient on our policies and procedures regarding advanced directives.
Everybody get a chance to? There ought to be an S behind podiatrist,
Well,
just to keep it consistent, plural.
Got it?
It's under tab 5, under intent and scope, first sentences, physicians, dentists, podiatrists, and didn't change the meaning. Yeah, 1200.
Thank you.
May I have a motion to approve it?
move approval of the advanced
For a
directive.
second. Okay. Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. It passes. 2100, refusal to honor advanced directive.
Yep, this also was amended with very non-substantive changes whatsoever, so it's very minor.
Everybody get a chance to look at it? Somebody like to make a motion, we approve it?
Second.
DT and Dorothy? Any discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. Thank you. Now we've got performance improvement reports, and I believe you're up.
Good afternoon. Thank you for the opportunity to present.
Before you go, does everybody know
Dr. Nick Harris.
Nick?
Hi. I'm happy to introduce myself. I'm Tim Nick Harris. I'm an orthopedic hand surgeon here at JPS, and I'm also the Chief Medical Informatics Officer for the Acclaim Physician Group.
Great.
So thank you for the opportunity to come and present to you. I believe Mr. Early at the last Board of Managers meeting presented an electronic medical record satisfaction survey that we participated in conjunction with IT leadership, including Melinda Costin, our physician informaticist groups, as well as our nursing informaticist group headed by Crystal Gandhi. We were approached by an ARCH collaborative, which is an initiative of CLASS, which is a nationwide research study, to be involved in a nationwide project to see how EMRs are perceived by physicians and what level of satisfaction and adoption this has been incorporated into our clinicians, both physicians and nurses, throughout the country. And so we participated in this study, and it was a survey that was administered to all medical staff as well as all nursing providers at JPS. And we found something very interesting. We found that here at JPS, we have a high degree of satisfaction with our electronic medical record, which is very different than elsewhere around the country. In fact, JPS Health Network is in the 93rd percentile of all institutions surveyed around the country. I'd like to take the time to show you where we rank among the entire consortium. We are number 2 in the country for total EMR satisfaction. This is among a whole bunch of different organizations, and you may see organizations up there that are big names such as the Mayo Clinic healthcare system, as well as others, some that are very advanced in their use of informatics and EMR adoption, some of which have been on the Epic EMR system 5 to 10 years longer than we have. And yet we have done something right here at JPS. And the CLASS initiative is very interested in what we have done here at JPS. Some of the things that highlight how important this is for quality is that when you look at just our physician respondents, our physicians feel that our Epic implementation allows them to provide quality care to our patients. And we have some of the highest levels of this sentiment around the country. If you then look at efficiency, providers in general feel that the EMR makes them inefficient. It has all these burdensome requirements, and that is a big reason for the basis of this study. And what we have found is that we have some of the highest perceptions that the EMR enables efficiency for our providers. This is important because it means what we do here at JPS is mitigating that sentiment better than elsewhere in the country. And while this is predominantly to look at the electronic medical record, there was something that came out of this 200-page report that I found most intriguing. And there was a question on this survey that said, do you agree that the work you provide is fulfilling? And we were number one in the country. Out of every one of our respondents, only 6 were indifferent to that statement, and the remaining several hundred either strongly agreed or agreed with that statement. So what I think we are seeing here, and is a testament to the work of the board and the JPS administration, is we have created a culture and sense of pride with what we do that is reflective in not only how we implement technology, but also in how we provide quality and efficient care for our patients. So I think it all goes back to Robert's Rules of the Road and the culture that we've created here that allows us to really perform above and beyond our peers in the country.
I think that's pretty impressive.
Well, considering the fact that a fairly short time ago, there was wailing within the halls and frustration, and this is the worst thing that could ever happen, I think we've come a long way. And the other thing, and I mentioned this to Chet, Nick, and Brian and yourself, you all as board members understand that you all can suggest certain things and we as administration can suggest certain things, but until you get doctors talking to doctors, it doesn't happen. So I have the luxury of having the 4 of you in here. I'd personally thank you because your efforts and the 2 of you made big differences, and that's what's gotten that satisfaction to where it needs to be. So I'm appreciative of our team, but very appreciative of you as physicians, because it has much more meaning when one physician talks to another. So thank you all.
Thank you. Appreciate it.
Take it back to the claim group.
Yes, sir. Thank you, Dr. Weber.
Good job. Thank you very, very much. Next one, patient experience update, which is Laura.
Hello again. It's been a little bit since I presented to you all on our satisfaction scores when it comes to our patient's perspective. So I wanted to spend a little bit of time today showing you what our, ooh, not sure what that is.
There you go. Well, they're just really making sure the sound works now. That's key. I'm very proud of them.
Wow. Thought maybe we were
On a video today.
It's all right. We got sound.
moving into Hollywood or something. I don't know. All right, so let's try this again. What do you want me to do?
Okay. He's back on the short-term improvement performance payment plan.
We do real well with EMR. It's just some of the other issues that we have. EMR, we're doing really great. But videos and soundtracks and those kind of things.
Can you hear Laura back?
Yeah.
Can you hear Laura back there? Go ahead. We don't have to wait for this.
Everyone? So while we're getting the slides up so that you can see the current results from our patient's perspective of care, wanted to just let you know, we actually focus in the patient experience world in 3 areas, and I'll cover all 3 of these today briefly. The first one is the patient, and again, just their perspective of care. The second one is how do our employees respond to that, and the third is our physicians. So we spend a lot of time in those 3 focus areas when it comes to the work that we do in patient experience. Are we good now or no? Almost done. Okay.
Don't hit that button again.
I am not touching it.
Keep talking.
I'm going to let them do their thing over there and stay out of the technology realm completely.
We have
which
the
is,
chief information officer there.
I know.
Work.
We may need to call her up here. you know, I'm really always overwhelmed at this team because the work that we do here every day, as you just heard, is really meaningful. And our patients respond to that in a really positive way. And we've worked very hard to create consistency when it comes to the way that our patients are treated, regardless of area that they enter, you know, how they enter, whether it's through the ER, whether it's through surgery, or even a direct admit to the hospital. And as we spend our time really working with our physicians in a much tighter way, we've done some really neat things. One of the things that is I'm really proud of our team for, frankly, is that our physicians and our executive team actually partner up every week and do rounds on our patients together. And we started with our first TCU cohort group. So there are 15 of the physicians in that cohort, and we partner them with our executive team, and we spend time going and talking to our patients. And what's come from that is this wonderful ability to see things from two different sides. And so I thank the physicians who are participating in that and the executives as well, but that's really been quite an enlightening piece of this puzzle, to be able to really see things from each other's eyes and see things from other perspectives. So we'll continue that work as we go forward as well. So you all have your information in your packets. The very first slide that you have shows our patient experience dashboard. This is a very brief summary. Our HCAHPS data, which is our inpatient data, fiscal year to date. So this is from October through just a little bit in January. We're still missing about 2 weeks worth of data, but we're at the 72nd percentile, and that puts us at our threshold. Our CGCAHPS, which is primary care only numbers, is again our fiscal year to date, and that puts us at the 29th percentile, again hitting our threshold number there. Our ED has been really a fascinating thing to study, which is at the busiest time during the entire year, being flu season and volumes higher than ever. Our ED, as of the date of this report, is performing at the 91st percentile, and that's in comparison to level 1 trauma centers across the country. So hats off to the work that's being done down there. That's really amazing.
Laura,
yes.
on the level 1 trauma center, how many is in that site?
There are 49 hospitals that are included in that benchmark.
Okay. All right.
All over the country.
All right. My final question on that is, that's a big jump from where we were.
It is. It is. Realize that a lot of times the large jumps that you see are small percentages, as you know from all of our conversations. But yeah, that's a big, big jump over where we were before.
Yeah.
This before the treatment or after the treatment? I'm just kidding.
I believe, although I'm fearful, you can pull that screen up, is what two people in the back of the room are telling me by their jumping up and down. So you can. Oh, you got it.
It's up.
Okay.
They did
I
it
was
for
looking
me. I'm not touching a thing. I go back to that.
You do have control of it now, though, if you want.
Thank
What happened
you.
to this one?
Yeah, well, that doesn't matter.
I appreciate that.
It looks up now.
Yeah.
Okay.
All right.
Okay.
A few months ago, whenever the last time was that I was here, we talked about a project that we have launched here at the hospital, and we at the time were a pilot group of one of 7 hospitals. This particular project has actually grown to over 50 organizations now and 10,000 members, all physicians, and it is a created for physicians by physicians platform for really focusing on some key areas that when it comes to the patient and frankly when it comes to the way we treat each other. We elected to launch our project with the goal of creating an increased well-being for our physicians, and so again that's where that focus on physicians, one of the focuses on physicians, comes in. And so I wanted to provide you with some information on where we are today. We did receive, as part of our pilot, an unlimited number of logins for this project. And so that is a substantial difference. No change in the cost, but they did allow us to have an unlimited number of logins for our physicians, which is fantastic. So far, we've had 174 take us up on this offer, and they have logged in 657 times. And when you log in, you can actually view multiple things. So we do track that. There's a point system that is tracking how many times our physicians go in and watch videos and post comments with other physicians around the world. And some of our physicians have really taken advantage of this, and the feedback that we've received from those who have gotten some really good nuggets has been really positive. Part of what we're doing here is working on the internalizing of a project and making sure that it works correctly for JPS. And so as part of the pilot group, I've been asked to participate in a national advisory board for this project, and really working with other organizations to learn what their best practices are and how we are doing it here, so that we can share what that is and increase physician awareness across the world, really. The topics that are most watched when it comes to the topics that are on the site are listening, explanation, physician well-being, and expressing empathy. So those are the 4 areas that we've seen the most traction. Additionally, we have worked with our academics department and with Dr. Tricia Elliott, and with that team, as well as with Acclaim and with all of the other orientation outlets. And we have now oriented almost 200 physicians in the past several months on patient experience. And so that ranges from anything from just allowing them an opportunity to see the survey, ask questions, really get a feel for what are the things that patients are measuring them on as far as the physician is concerned. That's been very well received, and then in addition, we're doing observations of physicians as well, so we can help them understand what it's like from the patient's perspective.
Laura,
Yeah,
before
sure.
you leave that.
Sure.
On the topics, is there a measurement to see if they have an increased knowledge or awareness of?
Yeah, so what we're doing right now is actually we just got the reporting capability a couple of days ago, so I don't have it today, but what we're doing is actually looking at who's watching what, and then we can actually measure the patient's perception of that particular topic. So, for instance, there's how often did the physician listen to you question, and so if they're watching listening, we can actually see what did that look like pre-project and post, and so we're pulling that now. The third area of focus is on our employees, and this is another mechanism that I mentioned a few months ago when I was here. I wanted to bring back and just share with you what the results of this have been so far. So we implemented Short Center Rounds, which is a care for the caregiver model. And we've had 5 of these sessions so far. To date, we've had 567 people who have participated in these sessions. And we have discussed topics in a closed room environment where it's very safe for people to just share their experiences. And they've been from anything from very tragic loss of a patient to how do you work with and partner with a patient who English may be their second language, or they don't speak English at all, or they have very different religious beliefs, or they have very different cultural background. And this has been an incredibly well-received program that we've implemented. We do measure the success of this as well. I brought one of the questions because I think this was really applicable to the patient experience, and that is, the question is, as a result of this discussion, I feel better prepared to handle tough or sensitive patient situations. So far in our 5 sessions, 90% of our participants have responded yes, that they did feel better prepared. The goal of that is support, but also awareness from the patient's perspective. This is also a follow-up from a few months ago where the request was made to provide different types of education to our patients. And so we have a
a technology platform that we utilize here. We're actually enhancing that at this time, but it's a technology-based platform that provides education on a variety of different diagnoses and diseases and different treatments. And it is a way that we can actually increase our partnership with our patients. And so it allows them the ability to watch a video from their home. So for instance, if they have a recent diabetes diagnosis, we can actually send them a link to the video. They can start watching videos and gain information on diabetes. So we are looking at different ways to utilize these videos, whether they be on a loop system within the clinics on the televisions, as was requested by some of our patient members last time we met. And we are also looking at how, when a patient has a new diagnosis, we can send that link through their MyChart so that we continue to increase their MyChart usage as well. And so between the rotating of monitors for things that are either timely, meaning flu shots, we can do some rotation of those, as well as that partnership with the patients when it comes to their individual diagnoses. I did want you all to know that we are currently working on enhancing that as we speak, and we're making some very good headway on that as well.
Laura,
Yeah.
as you work on that, when the patients leave, they have this nice printout that talks
Yeah.
a little bit
Yeah.
about their treatment that day. Could we have a statement on that?
Yeah.
That would mention the video, if we have videos available on MyChart. That would be a good
Yes.
part of that printout, that every patient, when they leave the doctor's office, they now have this. And if you could tie something in to print off there, mentioning the videos that they could look at based on their medical condition, I think that would be a great help.
Yeah, well, thank you for that suggestion.
If I wanted to watch one of these videos, how would I do it?
You can let me know, and we'll, for you personally, or for if you were a patient?
There's an educational
Right.
video. If
Sure.
I wanted to watch one, how would I do it?
You can let me know. We'll get you set up for it, and you can watch it. If it's a patient, then we can actually push those to a patient.
If you were
If
a
you-
patient, you'd have a MyChart, and then you would be pushed to that MyChart.
Correct.
If you don't have a MyChart, we'll let,
We-
anybody see those videos.
Yeah.
So you can get an education on them.
When you say push it to MyChart, let me make sure I understand it. I'm very familiar with MyChart.
Yeah.
When I pull it up and it's something on diabetes, there's a link there. There will be a link there if I want to look at. It'll just list videos, or will it list what they are?
It will list the link for the video. Now, there will be a lead-in that explains that here is, you were recently diagnosed. This is
Okay.
my own
All right.
interpretation, right? But you were recently diagnosed with diabetes.
Okay.
Here is a video link that you can watch.
Oh, okay. All right,
If you'd like to
all right.
learn more about it.
Now, that's not connected yet, right?
We have the ability to do it, but we have not connected it to the point that I just described.
Oh, okay. All right, okay. I'll look for it.
Please do, please do. We're constantly looking at
Yeah.
enhancements.
Well, I think it's an excellent idea, and it's a good way to continue patient education. And one of the groups that I work with is we are encouraging them to know what's in their medical record. For those of the JPS connection, we are definitely pushing for them to do MyChart, and so that's just a part of they're pushing that at the centers for everyone, to know about your health, so that would be good.
They're watching on their smartphone.
Yeah, absolutely.
Good.
All right.
Any other questions for Laura? When will you come back and tell us about some of this stuff you're doing? 2 months?
So, yeah, that's actually what we just talked about last week, was what's the frequency. So I believe we settled on every other time,
Okay.
unless there's something specific that you would like to know. I'm happy to talk about this anytime you wish.
I got it. Anybody? Any comments for Laura? All right.
Thank you so much. Appreciate it very much. Thank you.
That's all I have on the agenda, so now we'll head for closed session. This one's closed at
Oh, you got something for us?
14. Give it about 5 minutes, and then we'll
Okay.
start again. We have a couple of short things to do.
Okay.